Good afternoon, everybody. Hi. Good afternoon. Thank you all so much for joining Dr. Geppert and I this afternoon. I think you're really in store for a wonderful presentation. I've heard Dr. Geppert speak before, and she's absolutely wonderful. Dr. Geppert joins us today by WebEx. So, the Samuel C. Harvey Memorial Lecture Award is awarded annually by the AACE President for Leadership in Cancer Education. AACE established this Memorial Lecture Award in 1951 to honor Dr. Samuel C. Harvey. The 2006 lecture recipient, Dr. Ajit Sachdeva, wrote, "Dr. Harvey was a consummate surgeon, scholar, educator, role model, historian, and philosopher. He was chair of the Department of Surgery at Yale University School of Medicine for 23 years. He was president of the American Surgical Association and the first chairman of the coordinators of cancer teaching. It is my pleasure to introduce the 2017 Samuel C. Harvey Memorial Lecture Award winner, Dr. Cynthia Geppert." Yay! Dr. Geppert is the Chief Ethics Officer and Chief of Consultation Psychiatry of the New Mexico Veterans Affairs Healthcare System. Dr. Geppert was also the Acting Chief of Ethics Consultation of the VA National Center for Ethics in Healthcare. She is the recipient of numerous teaching awards and has been invited to give several scholarly lectures that range in topics from ethical issues in caring for patients with HIV, substance abuse and ethics, and pain and psychiatric comorbidities. Dr. Geppert is the editor-in-chief of the journal Federal Practitioner and has authored several book chapters and published numerous manuscripts in peer-reviewed journals. Additionally, Dr. Geppert has been extensively involved in mentoring and active in curriculum development. With all these accomplishments and responsibilities, Dr. Geppert was still able to be available to me at any time to help me with my most difficult ethics consults. I am forever grateful. Dr. Geppert is a trusted colleague. Dr. Geppert will be presenting the history of truth and hope in the ethics of cancer care. We'll be joining Dr. Geppert by WebEx. Please welcome Dr. Geppert. Thank you. Thank you, Cindy.
Thank you, Maria, for that warm introduction. Maria and I have known each other for about 20 years, and it's been a wonderful relationship for me. She's one of the best, most caring, kindest physicians I've ever known, and has really done a lot to teach her fellows in oncology, developing her own curriculum about ethics. I want to thank all of you in the organization for this amazing award. I would never have dreamed of getting something like this, and it's a great, great privilege when I read about Dr. Harvey especially. I also have to thank Maria and Jen for letting me do this virtually. When Maria told me I'd been chosen, I said, well, I can't accept it. My health is not good and I'm not able to travel anymore. And she said, well, we'll find a way. And that epitomizes Maria. So thank you again. The topic is one that I had decided on soon after being selected. And it turned out that once Maria had spoken with the planning committee, a lot of the questions and issues that they had brought up very providentially, I hope, sorry for the pun, fit in with our talk. And so I know we only have so much time and I want to leave time for questions. Usually I'm a very active speaker and I jump up and down and run through the halls and things, but I can't really do that because I'm here in the chair. So I'll try to convey that level of enthusiasm about this material. and look forward to talking to you. And again, thank you for all you do educating healthcare professionals and patients about cancer care. I think it's really inspirational, and I tried to capture some of this in the talk. So I don't have any external conflicts, and as I said, as a psychiatrist, I don't think you want to know about my internal ones. It would probably take us the entire rest of the conference into next year. And I am a dog lover. I have my dogs with me. I'm hoping they'll be good, but if not, I really liked this little cartoon. So I hope you can see everything, including me okay. This is a really revolutionary way to deliver this. I want to thank Jen again, who had to hound me for every piece of paper. She's amazing. And I think this is the wave of the future that will really have all access to all sorts of learning experiences we wouldn't, thanks to the internet. So this is one of my all-time favorite quotes from Rilke. And it's about living the questions and not seeking the answers. And I think that's really the theme of what we're going to talk about, and also working with patients confronting life-limiting illnesses. And somewhere along the way, you find your answers when you sort of give up having to have them. So the three questions that I really want to deal with today are: what if a patient doesn't want to know about his disease or state of health? What if a patient is unable to tell a physician is unable to tell the patient the truth? And do physicians ever have a duty to lie to their patients? And I hope I'll bring some light to these, and also get you to think a little bit as we go along. And we'll return to them at the end of the presentation. I'm going to give you 3 cases, and at the end of the presentation, we'll talk about them and go to the answers. But until then, I want you to just sort of think about them. And the first is, I won't tell her, and I'm just going to go through them quickly. So this is Dr. A. He's been treating Nicole in his oncology practice for 10 years. She's been in remission for the last 7 of those years, and she has a history of depression that's worsened with her recent divorce. She has been struggling with her cancer, but each checkup she's done well and she's feeling better. The results of the latest checkup, unfortunately, show the breast cancer has recurred, and worse than that, it's metastatic. She has a history of depression, and it's worsened with that recent divorce. Dr. A feels that if he tells Nicole right away about the return of the cancer, she'd become even more depressed, maybe attempt suicide, and he worries she doesn't have her husband to support her. Usually he would call her immediately with the good news about her checkup, but instead he calls and says that some of the tests aren't back yet, Nicole, and you know how I am about wanting to have all the information before we talk. And so reflect on, is Dr. A doing the best thing for Nicole or for himself, or both? The second case is the son knows best. Miss J, she's a Hispanic matriarch of a very large family, 6 children, 14 grandchildren. At 77, she's cognitively intact. She's been remarkably healthy except for diabetes. And she came to the hospital where she doesn't usually go because her family was concerned she was losing weight. And she tells the doctor she's had a change in bowel habits and some abdominal pain. Sadly, a colonoscopy and a PET scan show stage 4 colon cancer. Her eldest son is a family physician, and he insists his mother not be told the diagnosis, much less the prognosis. He tells the oncologist it's his responsibility as the eldest son to make her medical decisions and ensure she has the best care, but even more, it's his duty to ensure that whatever time she has left, whatever life is left to her, she enjoys. When you ask if he's discussed this with his mother, that she won't be told, he smiles and says, son knows best. Is Dr. Son right? You should ask yourself ethically. The final case is I don't want to know. Mr. D is a 35-year-old musician. He's admitted from the ER. He's brought there after collapsing on the stage at a local club where he was performing with his band. The oncology fellow is told to see the patient in the hospital. He's already reviewed the CT scan from the ED, and it clearly shows a spiculated nodule in the left middle lobe. Mr. D tells the oncology fellow he's been feeling really tired, but that's probably because he stays up at night writing songs and smoking tobacco and marijuana. When he comes to evaluate Mr. D, the fellow starts to explain his concern that the CT scan may reflect cancer. Mr. D stops him and says that he doesn't want any negativity, doesn't want to hear any downers, just for the fellow to do whatever he has to do to get Mr. D back to playing music like he loves to do. And the fellow wonders, what do I do now? So as I said, we'll return to each of these cases after the presentation. So these are two wonderful quotes that have meant a lot to me over a long career. While there's life, there's hope. So as long as, and actually Hegel paraphrased this and said, as long as there's hope, there's chance for reconciliation, one of our great goals with palliative care. And then the three things that can't be long hidden: the sun, the moon, and the truth, which will be a theme today, because even when people think patients don't know, they usually have a sense that things are not okay. So think about those. This is Tolstoy's The Death of Ivan Ilyich, which is probably the greatest story about lying to patients ever written. And it's often quoted, this particular passage. What tormented Ivan Ilyich most was the deception, the lie, for which some reason they all accepted, that he was not dying, but that he was simply ill, and that he only needed to keep quiet, undergo treatment, and then something very good would result. This is often quoted a little bit negatively against us doctors for not telling the truth, and it's a really profound book if you haven't read it. Where are we going? I loved this picture because I think what we're going to do today is really existential, which means we're going to, kind of like Kierkegaard would say, leap without a net, a leap of faith. And it just goes straight off this cliff. So where are we going today in the time we have together? Well, we're going to look at the history of truth-telling in medicine, the ethics of truth and hope, cross-cultural ethics. We're going to examine some of the empirical research on disclosure of cancer diagnosis and prognosis, and ask ourselves why people don't disclose, or when they disclose inadequately, and end with how we might more ethically communicate in a way that balances two essential elemental human parts of the human condition: truth and hope. So we're going to start with history, and I'm a historian by training, and I was really happy to see that Dr. Harvey was a historian and a philosopher as well, because I think unless we know where we've come from, we can't know where we need to go. And also, history is really neglected in bioethics. It's sort of like it's just the case in front of you. So unbelievably, and if you can remember one thing I say today, besides that my dogs don't bark, it's that for most of the world now, and for most of time since its beginning, since the beginning of healing in Egypt and Mesopotamia, patients have not been told the truth, and that was the ethical norm, and that was considered the kindest thing that you could do. I'll try to explain a little bit about why, but just to realize that our ethical norms about telling the truth, even legal now, are very, very new. And I'm not an ethical relativist, but I think that there are some things that changed in medicine, science, and society that made not telling the truth really problematic over the last 30 years. So that's in many of your lifetimes. So Hippocrates advised doctors to be, quote, economical with the truth and to tell nothing of the patient's future or present condition, because, as he later said, they might take a turn from the worst. Now, Hippocrates and the Hippocratic school were most widely respected for their ability to prognosticate. That was pretty much all that could be done then, and yet they didn't share that prognosis with the patient because they thought that they would either not adhere to the treatment or would become melancholic. And these same concerns will persist over and over. This is Dr. Thomas Percival, widely recognized as the founder of really modern medical ethics. The AMA code is based on his ethical code. And he said, the life of a sick person can be shortened not only by the acts, but also by the words or the manner of a physician. It is therefore a sacred duty to avoid all things which have a tendency to discourage the patient and depress his spirits. Now, at this point, most of you who are oncologists or palliative care doctors are really, really feeling pretty bad because, of course, everything that we do in some way involves telling people things that we would all rather not say or hear. I hope you end up feeling more uplifted, but we have to get through the dark stuff first. So, and I'm really glad we don't have to dress like that anymore. Studies of disclosure over time, and we're fortunate that they were done very early. So this is Philadelphia, which was medically quite sophisticated. In 1953, and nearly 70% of surveyed physicians would not disclose any cancer diagnosis at all. About 7 or 8 years later, 200 physicians, again in Chicago, found that 90% would not disclose a cancer diagnosis, and many would in fact give a false diagnosis. So not just withhold information, but actually lie to patients. And again, the reasons were not that they were bad doctors or mean people, but that they thought this would rob the patient of hope, that the patient would give up, that the patient might even die because of what they were told. So why do things change? Things begin to change in the late 1970s, again, when many of us were alive. A study similar to that I quoted before said now that 97% of physicians would disclose a cancer diagnosis. Why? What's different? Many things, more than I can really go through in this talk, but the profession of bioethics had arisen because of abuses in research, because of the civil rights movement, because of the rise of technology in medicine, and patient rights had come to the fore. For the first time, people are talking about those. Autonomy begins to be a concept that's not only entertained in ethics and medicine, but influences in 1974 with the common rule, the whole concept of informed consent in law. But more than anything else, my personal view is because we began to have effective cancer treatments. And I would argue, my thesis is that the reason truth has come to the prominence and become the ethical normative approach is because we have so many ways to take care of people, to not only cure them, but also to manage their illness, to make things like HIV chronic. And never before in the history of medicine has that been possible. So not telling the truth has ramifications that it never did even 50 or 100 years ago. So when my father graduated from medical school in 1939, there was really very little tiny pharmacopoeia, and his biochem book, you know, they hadn't really seen didn't have DNA, didn't know mitochondria, and there was very little that they could do for people. Antibiotics had not yet come. He used to tell me how antibiotics came about in the Second World War and first using them. So that's not that long ago, and there was really, there was a lot of therapeutic nihilism because we just didn't have the resources. You could always take care of patients, be good to them, help them, but as far as curing and treating, we had pretty empty bags. So also the rise of shared decision-making in the last 10 to 15 years as the locus of control in medicine rather than paternalism. And then with all those changes came a shift from not disclosing the diagnosis. We started telling the diagnosis. But as you'll see from the empirical literature that I'll review, now we don't tell the whole truth about the prognosis, because even though we can really aggressively treat things, there are still many diseases that are beyond us, as you all know much better than I do. And then, unbelievably, it is not until 1980 that the AMA Code of Ethics finally mentions that physicians need to tell the truth. 1980. Let's look at the basic fundamentals of ethics of truth-telling. So why should we tell the truth? First, we are involved in fiduciary relationships with our patients, which is a term in philosophy and law that means trust. We are in trusting relationships, in relationships that have a power differential that is most puts the patient, who is also vulnerable because their illness, at a disadvantage. And so we have to be trustworthy, and we have to protect their interests above all else. If a patient doesn't know what's wrong with them and doesn't know what the options are and doesn't know the course of the disease to the best of our medical knowledge, then they really can't make informed decisions. They can't decide what they want for treatment or don't, and how they want their life, however long it may be, to be, what quality, what quantity. Withholding information and certainly deception may cause greater harm than telling even difficult, harsh truth, not in a harsh way, but hard to hear, if you do that with support and hope. And the empirical ethics studies that we'll look at show that not only do most patients want to know the truth explicitly, but they already know it implicitly. They know their bodies. There's a wisdom of the body that overcomes the mind and sort of says, this is just not okay. Sherwin Nuland, the great surgeon that just died, actually has a very good book called The Wisdom of the Body. And finally, paternalism has really lost any traction ethically or legally, except in true emergency cases or with persons who absolutely have no one to decide for them. And the concept of therapeutic privilege in law, that physicians have the right and the ability to decide what patients are told, has also really fallen out of favor. I can remember when I started, a patient, especially a psychiatric patient, was not allowed to see their chart. And if they did ask to see it, they had to sit with you, and you had to tell them only what you thought they could tolerate. Now we all, at least in the VA and many other large healthcare systems, have open access medical records. Patients can read exactly what you wrote at the time you wrote it. And so to not tell the truth has become not only not ethical, but practically really difficult. What are the ethics of deception? That may seem strange that I'm putting both of those in the same phrase, but there are actually physicians and ethics experts, not just in other parts of the world, which we'll talk about, but here in the United States, who believe there is a place, a small place, for deception in modern medicine, and they've developed ethical guidelines for when not telling the truth might be the most ethical course. First, deception has to be the last option. No other ways of trying to resolve whatever the ethical tensions and conflict are could be available. Second, there must be a very strong ethical justification. I'm going to use this because it's the only time I've actually ever agreed to it. I had a critically ill patient whose favorite son, only son rather, had been killed in an accident, and neither his physicians or his wife felt that he could withstand it at this point. And the deception has to be small. So I know your son loves you and would come and visit if he could when the patient was asking for him for a day or so until he got over the crisis. And the benefit has to be great. In other words, this was an ethics consultation. Everyone agrees that this minor lie enables the patient to stabilize medically so that in a few days, with support from chaplain, family support, he can be told of his son's death. Now, as we'll see, there's some ethical theories that would not buy the logic of that period, but I think that at least this is a case that can be entertained, that at some point, very few, there may be reasons to deceive, but we better really, really, really have good reasons. So I was talking about ethical theory, and in deontology, which comes from Kant, in duty or rights-based theories, there's never going to be a situation in which one would deceive. The obligation to tell the truth is absolute. This is the famous philosophical conundrum of the Nazis come to the door and you're hiding Jews in the basement, and if you always have to tell the truth, then yes, according to Kant, you tell the Nazis that the Jews are in your basement, needing their death, and that, of course, seems beyond barbarism and quite absurd to many of us. But if you were a thorough-based deontologist, that is the answer. Human beings can never be treated as a means, only as an end, and so to lie to someone is to make them a means for either you or some other third party's vision of best interest. There is absolutely no exception. You cannot lie to patients, and the arguments that truth could harm a patient and that harm should be so great that it would outweigh your obligation to tell the truth carry no weight. Let's compare this to the other end of the philosophical spectrum in utilitarianism or consequentialism that John Stuart Mill is associated with. The ethics of truth-telling should be determined on a case-by-case basis, and the right decision is that which brings about the most good for all concerned, not just the patient. And the effect on the patient, the family, and other parties must be carefully evaluated. So you can see how different those positions are, and as we go through the talk, you can decide whether you're more on deontological or utilitarian, and share your preference with your friends and tell your patients. So truth-telling and informed consent are two very closely allied ethical and legal constructs. We all know as healthcare professionals, and if I sometimes tend to use physicians more than others, it's not that I don't value every nurse, social worker, therapist in the room. It's because I'm a physician, and unfortunately, most of the studies that I'm going to review are going to look at physicians. But that doesn't mean that every healthcare professional involved in cancer care, the care of any serious illness, doesn't face these dilemmas. So consent requires disclosure of, quote, adequate information to enable the patient to make a decision, and adequate will be a bugaboo. Failure to disclose, then, that adequate information has both legal and ethical ramifications because a patient is not able to exercise their own self-determination to make decisions. Some physicians, older physicians, some specialties, which I won't mention because I'm kind and ethical, argue that patients can, and I have a bizarre sense of humor, so it isn't probably coming across the same way on a little screen, but I think if you don't have some laughs, it's hard to learn. So some physicians would say that patients can never really understand complex medical information, in other words, objective truth, and so consent is not really possible. My answer to that is that's true. I don't think at this point I would even understand most medical information. I'm so far away from things like OB-GYN. Second, I think that when we're upset and a loved one's health is on the line, even we as physicians don't really understand everything we're being told. But that does not relieve us of the moral obligation of trying and of doing our best to communicate. We still have that duty to disclose all the objective truth in a way that patients can hear it. And it doesn't mean every technical detail, as we'll see, but the substantive truth. In other words, what matters to the patient? What matters to the patient in their life? And decisional capacity is actually my area of expertise in specialty in psychiatry, and over many, many years of doing thousands of ethics consults and psychiatric consultations, I've seen very, very few patients that cannot grasp the basic choices of their condition, life or death, who loves me, who doesn't, and usually that's an acutely psychotic or severely demented person. Otherwise, I think if you're a good communicator, you actually can obtain some form of elemental consent. I want to take you through a case that I think is very, very illustrative of all of these sorts of social and ethical forces coalescing and the law kind of catching up, and also medicine in some quarters being a bit behind. So this is a famous California case. It's from the early 1990s. A patient had a kidney operation. He was 43, and unexpectedly, the surgeon just thought that he'd be removing a kidney that wasn't functioning. He found pancreatic cancer. He removed the tumor in the lymph nodes. He met with the patient and told him he thought that he got all of the cancer, but referred him to a medical oncologist for follow-up. He never told the patient that less than 5% of patients at that time with pancreatic cancer were alive in 5 years. And the oncologist told the patient that if the cancer recurred, which was common with this type of cancer, that meant the disease was incurable. He recommended experimental chemotherapy and radiation for the cancer to try to prevent recurrence, but he provided no prognosis. The cancer recurred, but no one told the patient that that meant he only had months to live. He didn't ask, so he didn't tell. Unbelievably, this used to be a quite common defense, both for not disclosing and if there was any legal action. The patient died within a year of his initial diagnosis. His wife and adult children sued. They claimed that the surgeon and the physician breached California informed consent law because they never told him about the grim, life-limiting prognosis. The plaintiff alleged, the wife and the children, that her husband at the very first oncological appointment had indicated he wanted to be told the truth if he was seriously ill, if he was seriously ill now, or any time in the future when he signed a very large questionnaire that he filled out at the beginning of his treatment with the oncologist. The physician's defense was paternalistic and covers many of the obstacles we will still see are barriers to complete disclosure of prognosis these days. So it was medically inappropriate to try to tell a patient that he was going to die from a serious cancer soon. It would create anxiety in this young man who had, at that time, small children. It would rob him of hope, of being able to enjoy whatever life he had. And then there was a lot of emphasis put on the average statistics, which is what statistics are meaningless for individual patients. And then finally, the strongest argument of the defense was that the patient never asked for his prognosis, and if he didn't ask it, then he must not have wanted to know. The patient's wife alleged that she believed her husband would not have undergone the experimental treatment, which made him quite ill, if he had known his prognosis, and instead would have gotten his life in order and been with his family. Mm-hmm. So what is the verdict? The trial court ruled in favor of the physicians, but when the case was heard before the Court of Appeals, that decision was reversed. The court ruled that no, physicians have an obligation under informed consent law to provide patients with prognosis, including life expectancy, so they have the opportunity to settle their affairs. They appealed to the Supreme Court, the physicians did, of State of California, which upheld the ruling and stated, physicians are dependent. Patients are dependent on physicians for truth, and they must trust them, which makes the doctor-patient relationship, as I had earlier introduced it, a relationship of trust, a fiduciary relationship, not just a contract. So I'm sorry that the slides are jumping a little, and I apologize. I'm not trying to have everybody need Dramamine. And I know you guys are tired, and it's going to be dinner time and celebration time soon, so don't mean to make you dizzy. Why do clinicians not disclose? So there are hundreds and hundreds of articles on this subject, many of which I read over the last months since I was given this great honor, and they all come down to pretty much similar causes. Why do docs not tell the truth? Well, they're afraid they're going to make the patients ill psychologically. They believe patients don't want to be informed. It's in our own self-interest. It's very hard to have difficult conversations. It's very hard to talk about death. We're better than when I trained, but we still have a way to go. Families often ask patients, please don't tell. Please don't tell our relative, and we'll look at that. We don't get enough training even now. There aren't real good guidelines, and we don't understand the research. Language barriers, culture barriers, both of which I'll talk about, and not having the time to sit down with people, not having an appropriate setting. You know, standing in the hall of an ICU or of an oncology clinic may not be the best. So what do we do? Well, let's look at each of those in turn and see if we can bring some illumination to these assumptions. Fear is both family members and clinicians share this fear that if a patient knows they will die sooner, that they will suffer more, and so they collude together to protect the patient from the truth. It isn't clear that not knowing you're going to die is more psychological distressing than knowing you will with support. We'll look at the little empirical data that is, and it's also not clear that everyone, when told they have a life-limiting illness, becomes so hopeless that they don't pursue treatment. In fact, everybody sitting in the room, which I wish I could see you all, knows many people who have been triumphant, had come to peace, and all sorts of that life fulfilling things when they had very little time left. That's one of the things we as palliative care doctors really hope that we can bring to patients and families. When patients don't know the truth of their condition, we believe that what we do know is they're much more likely to want a cure. They're much more likely to demand longer life. They're much more likely to want extensive, aggressive treatment, to refuse to be DNR, to not want treatment withdrawn, to demand, third-line salvage chemotherapies, to be angry when treatments don't work, because they think they have an unrealistic view of the truth because we gave them false hope. So when the patient is not told the truth, as I said before, they often guess it, they often know something's wrong, and that causes emotional distress because they feel like people aren't close to them, they aren't being honest, they can't trust their doctors, they can't trust their family because of that collusion. So 106 patients with advanced cancer, 3/4 understood their diagnosis, but then when it came to prognosis, only about half really felt that they grasped it. And of those, they wanted to know when they knew about the prognosis, but 22% were unaware at all and unrealistic about life expectancy because, unlike the 54% who knew and wanted to know, they wanted to know, but they hadn't been told. 28%, almost 30%, had unanswered questions going back to Rilke regarding disease progression, how they would die, and their prognosis. The bottom line of this very large this study in psycho-oncology and several more like it are that yes, when you know that you're sick, when you feel ill, you're more likely to be distressed. But just knowing you're going to die or you have a life-limiting illness does not cause depression. The prognosis alone doesn't cause depression, and I've seen more patients be depressed when they, in fact, don't know what's going on, and they have to keep trying and trying for a cure, even when one is probably out of reach, but the family insists that they keep trying. Another very important theme is that everyone is an individual, even in cultures such as Asian cultures where non-disclosure may be the standard or has been the standard. Surveys show that when you ask the patients themselves without their family, the majority still want to know the truth. The opposite is also true. Even in the United States, where truth-telling is now normative, there are going to be patients and families in your practice who want either non-disclosure or very partial disclosure, or disclosure only to another family member, or disclosure about what they have, but not if it's bad news. I mean, that's just human nature. So how much truth to tell and how you tell that truth has to be individualized according to patient's age, education, culture, background. A lot of research now is about the type of cancer, the stage of cancer, and other factors, and also many other things that we haven't even begin to disclose. One of the other reasons that in the literature it shows that physicians don't want to tell the truth is because it's better for them. In the days of Hippocrates, in the days of even my father, when we didn't have much we could do for folks, then telling bad news really could rupture the relationship. It could affect your reputation. Remember, at the end of the Hippocratic Oath, it say, "May I be honored by all men," etc. So it could ruin your reputation. You could not get paid. I'm being very crass, but it's the truth. And these days, it could affect patient satisfaction. And so there's lots of other pressures saying, don't tell the truth. There have been studies that show at times the satisfaction in some people was correlated with not giving a patient bad news. I like that doctor. Continuing treatment, even when there was the burden outweighed the benefit. And then really, really down to the wire, giving bad news is very hard. It's painful. It takes a lot of skill. And especially if we haven't come to terms with our own mortality, or we have our own psychological gaps and baggage about that, then it's very difficult. And if we've never been mentored, if we've never seen a Maria Bishop or many of you others do a beautiful job of a very, very painful thing, then we don't have those communication skills. And then, we want people to get better. That's why we all become healers. And so often it's admitting defeat. And unless we reconceptualize hope, which I hope to at least introduce in this talk, we may feel that we're abandoning the patient, that we have nothing else to give them or do. One of the most difficult dilemmas, and it came up in the questions from the planning committee, it's in the literature, is family request of don't tell the patient. In many cultures, this is the standard, and they are acting beneficently. They don't want you to tell a loved one they have cancer. Cancer is very stigmatized. But you as a clinician don't have an obligation to, shove the truth down their throat, but you do have an obligation to ensure that the patient really doesn't want to know, or they really want the family member to know and the family member to make decisions. It's important to avoid, cultural stereotypes. You may see a person, an 87-year-old Japanese lady who all the literature tells you doesn't want to know the truth and wants her son to make the decisions, who is completely independent and wants to be autonomous and says, what are you doing talking to my son? Talk to me. But conversely, you can't force the truth. One of the articles I read that I really like is, they told me the truth like hitting me over the head with a sledgehammer. That's actually an article. I think it's a great title. And patients need to decide, do they want all the details? Do they want all the probability? Do they just want the big picture? Do they not want to know it all? And so it's important to realize ethically, and often trainees don't get this, is when a capable patient says, I don't want to know, or defers the decision-making to a surrogate, or even to the physician, they're choosing, they're exercising their autonomy. And so we can't force the truth on them and deny it just because we have this informed consent doctrine in our head and we're worried about lawsuits and we say you have to know the truth. So you have to respect, if you're going to respect patients' preferences, it's even when it's not what we as docs want. So this was a really interesting study of oncology program directors in 2009, and nearly 90% of those directors said, nobody taught us how to give bad news. I mean, now we do it in medical school. But even then, the fellows, almost 40% said nobody trained us, and only a quarter or less felt that they'd been given, extensive training. And 63% of the directors said, yeah, we need more formal training in delivering bad news. We need more experiences in developing communication and interpersonal skills. And that's 2009. That's yesterday, when you're as old as I am. Language and culture are also huge, huge barriers. I like this little cartoon because not only is the little guy French, but he's a mime, and so it's going to be a very difficult translation for Spanish. So when family members act as interpreters, which is, not something that cross-culturally is thought to be standard or acceptable, then often the diagnosis and prognosis is really filtered. It could be concealed depending on background and attitudes. But even more important, I think, for us, is that even when we speak the same language, even when we're both speaking English and we have an intelligent, educated patient, we are not speaking from the same culture and not in the same terms because they don't speak medical. They don't speak the jargon. They don't know the terms. No matter how, studies have shown no matter how simple or how lay terms we try to get at, we still sound like, textbooks. And so they may not end up appreciating the life-limiting nature of the condition. When I train residents, I say, don't say pass away. Don't say not make it. You got to say the D word, die isn't dead. And they're like, well, that's just too hard. And I say, then somebody's going to give that the best interpretation possible. You want to do it with compassion, but you still have to do it. I love this because if you're like me, you're running constantly. And there are 100 people around you and you never have a second, and the idea of sitting down quietly with somebody for 20 or 30 minutes really in a nice room seems impossible. And so the one thing we want to give the most, and if you look at studies, what patients want the most is to be talked to be heard. And yet that's the one thing we increasingly don't have. We're either on a computer, or we're in a car, or we're going from place to place and doing thing to thing. And so what patients want is time to listen, time to be heard, to ask questions, and to discuss. So I would hazard that having appropriate time and place is the hardest thing to get. We should be reimbursed for thinking and talking, and we're not. That's not where our healthcare system is set up. It's set up to be reimbursed for cutting people open and giving them chemotherapy, and in my case, hospitalizing and other things that are not really what patients want or need. So let's talk a little bit. It's certainly far, far better. But Susan Sontag, of course, wrote about the metaphor of cancer, and we all know when that was a death sentence and when that word was very hard to say. In most of the 19th century in Europe, you just didn't say the word. You never would say it to a person of any gentility. So what makes telling the truth about cancer, which is what you all have dedicated your lives to doing, so hard? Part of it's because people still are terrified. They still see it as something that's incurable and that will be a painful death. And that is all caught up in those metaphors, as Susan Sontag said years ago. It's hard to talk about prognosis and diagnosis. It's complicated, and the severity and all the variables. It's not easy intellectual task. Patients are scared. They may feel ill. They're exhausted, and that makes them vulnerable to almost anything we say, so the stakes are very high. It's very intense. In some cultures, in some circles, a person with a cancer diagnosis becomes isolated. There's still a number of types of cancers that I think are more stigmatized than others. They may feel discriminated against. They may be worrying about their job. They may be worrying about their family. All of our treatments, I love Star Trek, and I love, when even in the early Star Trek, when Dr. McCoy says, "I can't believe they poisoned people and burned them," and we wonder if in 100 years we'll look back and say that. But our treatments have lots of side effects, and bad things can happen when we're trying to bring good things. And so I think that's another part of it that makes it very hard to talk about what we need to do. I mean, we cut people open, we give them chemo, we radiate them. Care is really fragmented. And specialized care makes it hard to have the kind of close doctor-patient relationship that a lot of the literature on truth-telling is grounded in, a way of taking care of patients, I think, is vanishing and makes really hard. It doesn't mean you can't do it, but you have to work even more intensively at it. And then we talked about there are a lot of individual and cultural barriers to what truth is to one patient or another. I really want to recommend the article that from the Lancet that is referenced there, one of the best of all the hundreds I read, and I recommend it to you. Can you tell and dump too much truth? Absolutely. You can absolutely tell too much truth or in a way that's too harsh. So I remember years ago I had just become an attending, and we got a call from one of the floors where and this is not to say anything against surgeons or anyone else, this was just this case, a PA for one of the CT surgeons had come and told the patient, you have incurable lung cancer, you're going to die, you might as well go home. The patient had a very long drive in rural New Mexico and had told the nurses that he was going to kill himself on the way. And so as the consult psychiatrist, we went up there, and indeed, that patient had too much truth just dumped on him. When we look at studies, what do patients want? What are their preferences in really advanced illness? Almost all the patients want to be told, want the treatment team to be honest, and they want to know in general their prognosis, but there's huge differences in how much quantitative data and how much detail patients want. Patients wanted realism, but not so brutal that they lost hope. They wanted realism, truth that gave them control over their lives and allowed them to do end-of-life planning and live their life to the fullest. But for some patients, the whole truth and nothing but the truth was not reconcilable with any measure of hope. When they were given completely unequivocal or incredibly detailed information, you have glioblastoma, at the best you can live 6 months, it's going to be a really horrible death, they just could not continue existence with that. And so there is a place for subtlety and ambiguity and all those words that aren't actually negative in this sense. So we're moving into a phase where we're going to talk about how do patients want to hear the truth so that they can keep hope. So 240 outpatients at a large cancer center. They're asked about their preferences for delivering bad news. They were given questionnaires about content, about facilitation, about how, when, where, about empathy, and what kind of role they wanted. Did they want it to be collaborative, shared decision-making, or did they want it to be passive and paternalistic? So what makes the truth from those studies so different for patients, for cancer patients? There are different kinds of cancer, but all of cancer care can be really pretty hard road. They wanted to ensure that they had informed consent for all the patients. They wanted it to be available and have a good quality of information. They wanted to give, providers wanted to give cancer patients statistical information, but not underestimate that medicine is an art and not a science. They wanted more than anything to balance truth and hope, especially when discussing progression of cancer, especially when discussing that point where you change the treatment plan from active treatment to palliative care. That's what many physicians and patients said was the hardest. And those who did research were very wary, or not, but referred to research, were very worried about patients really understanding clinical trials and the risks of engaging in experimental research. And that's a whole nother topic, but it is something important increasingly as clinical trials move to the private sector to mention. Particular obstacles of oncological care that made it difficult to disclose. Therapeutic misconceptions, in other words, thinking this isn't research, this is treatment, this is going to help me, not society. Medical errors, and then wondering where to go and trying to pile on more treatment because we messed up. Genetic, increasingly information, how do you tell them that their child may have this, they passed it on? How do you tell the family that they need to ask their parents? Misunderstandings in cross-cultural encounters that we talked about. And then, you know, you're not just treating the patient, but you're treating the family as well. What do patients want? They wanted the doctor to tell them the best treatment options. If there's one single variable in all these studies, it's they want a doctor who's competent, who knows his stuff, and who can tell them all the possibilities that are available. They want to be told in person, not on the phone. They want the doctor to be on the cutting edge of their therapies for their type of cancer. They wanted all their questions answered. They want to be honest about how bad it is. Again, they wanted time. They want all the options. They want to be told as soon as possible, and they want the doctor to attend to them. But the number one thing was that the doctor knows his material, that he's competent, and he knows about the latest treatments. What they didn't want was to see a bored or disinterested physician. They didn't want somebody who was annoyed and impatient with questions, who interrupted them when they wanted to talk and changed topics when they needed somebody to listen, that was very abrupt, like the story I just told you, and giving bad news. And they didn't want the family member told before they were told. Of all these studies, what is it that we can do better? The doctor doesn't give or is vague about prognosis. People want to know. They may not want to know all the gory details, but they want to know the big picture. They don't want a physician in training to tell them. Now, I know we have to train. I've been a medical educator all my life, but we can do that best by at least starting out in mentoring and modeling, and then as we go up to the fellow range, you know, watching them and coaching them to do it. But, you know, sending a medical student, which I've seen happen, or an intern to tell you that you have cancer is not okay. Don't use medical jargon so that you can't understand as an obfuscation technique. Don't give news to others, present, family, friends, other providers, unless the patient knows and asks you. Don't, you know, invite the patient to tell you their reaction, their worries, their fears, their dreams. Don't answer pages and cell phones when you're telling patients bad news. You know, if somebody says, stop, enough information, can we talk again? I can't process this. Then give them room and give them time. And make sure you know if they want their family present at what point in the discussion. This is something many of you probably know well, but it's the approach to delivering bad news that's been the most validated in the cancer literature. And 6 steps, I won't go into them. They're pretty self-apparent. Setting up an interview, quiet, calm place, assessing where the patient is, what do they know, what do they want to know, inviting, having them say, I'd like you to tell me, giving knowledge and information, the part that we do the best, and then the part we do the worst, even psychiatrists, addressing the patient's emotions with empathy, and then figuring out, you know, where are we going to go from here with the treatment plan, instead of starting with the treatment plan. I love these. I just wanted to leave you with these phrases, which everyone often asks, how do I start the conversation? How do I continue the conversation? Saying, I wish things were different, which is a great palliative care phrase. I can see you're upset. Basically, these are not so much medical jargon, they're humanity. They're human beings being compassionate. I can tell you weren't expecting this. I know this isn't good news. I'm sorry, this is hurting me to tell you. I was hoping for better. This is really difficult for me. Now, you don't want to focus it on you in the sense that you start saying, you don't know how hard it is to be an oncologist, but you do want to show that you're a person, that you relate to them, and that this is affecting you as well. The studies on hope, they're far less, but how to provide realistic hope with life-ending, when you have a cancer that could end your life, not providing realistic hope is as unethical as providing unrealistic hope. So not providing realistic hope, in other words, just being grim reaper, is as unethical as providing unrealistic hope. In studies at Baylor and their large cancer center, they identified two kinds of hope. There's general hope and specific. Specific hope focuses on a particular future outcome. I hope that CAT scan doesn't show a recurrence. I hope this chemotherapy works. So something that's possible, but it also has uncertainty. Generalized hopefulness is a sense of open-endedness. Can we enjoy what time we have? Can we believe in something? Can we have reconciliation? So specific hopes as the disease progresses are harder and harder, but general hopefulness becomes bigger and larger and more powerful. And objects of hope change over time, and the greatest skill for a clinician, oncologist, or palliative care is to follow that change and help the patient adapt. And that's our duty, is to help the patient to go from I want to be cured to I want to have some remission to I want my symptoms relieved to I want to go home on hospice, and to help them find personalized, realizable goals. You know, staying on the ventilator until you see your grandchild, or whatever it is. You know, staying alive for your birthday. There's many, 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 many goals. There's many goals as there are people. Practical advice to end with, unless a patient really tells you, I don't want to know, I don't want to know anything, then you need to be honest and open, but not blunt, not hitting them over the head, not giving too many facts and details. Always be reassuring, always be compassionate that no matter what, even if you can't cure it, you can stay with them through the illness, whatever that means. When you can't treat the disease, which the oncologists I've spoken to in the literature would say is really the hardest part of giving bad news, then you need to switch gears and stress, how can we make you comfortable? How can we stop the pain? What are you most fearful of? What's the biggest burden to you? And how can we relieve that and support you? Promoting patient autonomy. If there are any, whenever there are choices, give them the choices. Would you like to try, this or that? Would you like to wait or not? The most simple things about advanced care planning and about treatment and about their personal goals. Why don't you go on the vacation for 2 weeks and then we'll talk? It's not going to make that much difference. And as I said, there are as many ways to have hope in the face of terminal illness as there are individual patient stories. Where do we go from here? Future research, sex, age, education, socioeconomics, variations in the need for information, discordance of perceptions, differences in truth-telling in different specialties, and how do you talk to people in marginalized countries, strategies to effective disclosure, time and extent of release of clinical trials, genetic information, role of communication in decision-making, and how do we teach and train and evaluate those skills. And here are our cases, and here are the answers. Nicole has to know, we have to tell her, but you can call her in, maybe get her psychiatrist, and let her know. Then with more support, the son isn't right, you have a tough job, but you got to speak to Mrs. M about whether she wants to know or not, and she wants to make her medical decisions. And if Mr. D really doesn't want to know, he has lung cancer, you can't continue to throw it at him. You just have to try to provide as much general information to get him to the biopsy and the interventions. I'm going to leave you with this quote. I won't read it to you. I would ask you to read it silently. I think it's a really beautiful, beautiful quote that says truth and hope really get balanced in the relationship. And this is my all-time favorite quote about truth, because it says truth is really subjective and is what the doctor and the patient, when they're looking at those questions of Rilke and they're out there trying to find them, where they end up. Thank you very much. It's been a great honor, and I'm happy to answer questions.
Thank you, Dr. Geppert. Dr. Geppert, thank you so much for your insightful, interesting, and really instructive lecture. We truly really appreciate it. For those of you that have questions, Dr. Geppert has offered to host a kind of a webinar. If anybody would like to, let me know about questions, and we can set up a time to all meet in our respective offices or homes, and Dr. Geppert be willing to host this for us. As we have other sessions coming, we have time for maybe one question. Kathleen, do we have time before the next session? Just for one? Yeah. Dr. Al-Kursi, were you sure? I think we have time. You sure? Yeah. Would anybody like to? Yeah. Okay, Ringo, go right ahead. Yes, she can hear from there.
Okay. Hi, my name is Ringo Leon from UC San Diego. So you mentioned a reason why physician may not disclose patient diagnostic or prognostic truth is because the family requests so. In the case of Mr. Arado, who is 43, the physician was held accountable by the consent doctrine. However, in the case of a minor under the age of 18, say the parent or guardian asks the physician not to disclose the truth to their child, who is still under their legal watch, how would that situation be justified or ruled upon, especially if the child finds out the truth later on and wonders why he or she wasn't informed earlier?
All right. Cindy, were you able to hear that okay? Hello, Cindy?
Can you all hear me?
Yeah, now we can. Yes, now we can.
So that's it, and I apologize that we didn't leave more time for questions. I think we started a little late, and
Yes.
I had timed it, but it wasn't perfect, and I greatly apologize.
No.
That's a really complicated question. It depends on state law and what state law allows the minor to consent for. There's increasingly in both law and ethics a recognition that adolescent cancer patients should be able to make their own decisions, and courts have not always upheld it, but in many cases they have. I certainly would think long and hard about how to handle it, get legal counsel and ethics consultation, but the tide seems to be going toward especially older adolescents deserve to know the truth.
Ringo, okay. Thank you, Cindy.
Thank you for answering my question.
Yeah. Cindy, what I can do is speak with the audience and see if they have questions, and you and I can make plans to host some questions.
Yes, thank you, and I apologize to the next speaker and for making anyone late.
Oh, no apologies. We greatly appreciated your time and your expertise. Thank you so much.
Okay, have a nice day.